re-endos, and the whole work. So it was kind of very wet-handed dentistry. So I was able to kind of develop quite a lot in that training year, which was really useful. Right now, I'm working in a practice over in Wimbledon Village. Some of you guys may have seen the principal, so it's Vish and Aaron that you probably would have come across in terms of the endo page. So Aaron's kind of one of the principals, and George, who I'm sure many of you would have come across on Instagram as well. So that's kind of the guys that I work with over there. Just before we kind of get moving on, I wanted to kind of share some news about a new dental platform that hopefully will, I guess, in the next few days and weeks will be very active. It's called Kaizen Dental, which is, I guess, a new platform for young dentists, students, and kind of therapists, essentially kind of sharing clinical tips in a very bite-sized and easy to understand, I guess, format. We're looking to essentially kind of reference back to some articles and journals so that you guys can obviously see the work, why we're doing it, and the evidence behind it. There's a QR code on the screen. So if you guys get your cameras out, you'll be able to kind of go straight to the sign up page. The content is completely free. And the USP of what we're doing is essentially to kind of send out this information directly to your inboxes. So you don't have to go searching for this information, and it's going to be essentially at your fingertip. At the end of the presentation, I will show you guys an example of kind of some of the content that we're going to be doing, and some of the stuff that you'll see throughout this presentation will be, again, kind of, I guess, you know, on the same sort of topic in the Kaizen stuff that we produce. When you do sign up today, you will actually get a free PDF on how to do kind of diastema closures, freehand and composite bonding, which I'm sure a lot of people kind of, you know, are interested in how people do these kind of lovely cases that you see on Instagram and kind of all other social media platforms. So if you are interested, feel free to sign up. Like I said, it is all free, and I will show you at the end some examples of what we're going to be sharing. So let's start. So the obviously purpose of today's webinar is to kind of give you guys an introduction as to kind of what I'm doing and how I kind of got to this point from dental school, or DFT. Like I said, I graduated in 2018, finished up VT in August of 2019. So I was only working, well, as an associate since kind of September. And it's kind of just giving you guys an idea as to how you can transition into private practice and the tips that you need to do along the way to kind of maximize your chances. And then obviously afterwards, we will go over some cases and just kind of giving you an idea about composites, because I'm sure that's kind of what a lot of people are interested in as well. My philosophy is to kind of simplify it and dumb it down as much as possible. So hopefully that kind of resonates with some of us here. So I graduated from King's, like I said, 2018. Whilst at uni, I kind of got involved quite a lot in a few different projects, and I took on a few committee roles, which helped me. The reason I mention this is because it's really useful when obviously coming to apply for an associate position to, I guess, showcase to the principal or to the person that is employing you what you do that's kind of more than the other candidate. And this is kind of where you need to recall back to kind of what you've done in the past, be it kind of, you know, if it's kind of a business that you've had on the side, you know, charity work, or kind of whatever you've done during dental school, which is going to be helpful as to set you apart. So for me personally, it was kind of, I was president of King's Dent Soc for obviously a year, which helped. Because obviously that helps build your network and obviously helps build your communication skills and all these other amazing skills that you need to be a dentist. Again, I guess I got involved with kind of a few projects and presentations and research stuff, which again helped me when it came to, you know, having some conversation that was different at the interview stage when it came to applying, and also some prizes. So kind of apply for everything that you can during dental school, because I'm sure there's quite a lot of prizes up for grabs. So, you know, just get involved, get stuck in. Like I said, VT or DFT, I finished that in August last year, and I did it in Northeast London, which was, like I said, a very high needs area. So the majority of what I was doing was kind of, you know, extractions or re-endos or surgicals, and a lot of anterior caries and composite stuff, and posterior caries and composite stuff and amalgam. So again, really good, useful experience to get involved with. And one tip I would give is kind of, when it comes to choosing a DFT practice, make sure you choose something where you know you're going to be involved in doing a lot of work, because that's the whole purpose of the year, right? To kind of get involved and essentially do as much clinical dentistry as possible to up your skills. So make sure you try and choose wisely. So that's kind of really important. During my VT year, I managed to get onto a course over in Milan. It's a Stile Italiano course. I'm sure some of you guys would have heard about Stile Italiano as a group. They're really, really cool group of dentists, and it's a kind of international platform where you can kind of see, again, their resources and content that they're publishing. But essentially it was kind of a 4-day program that was, I guess, based on, you know, composites anteriorly, posteriorly, but also on onlays, veneers and stuff like that. It's quite intense, but really, really helpful. And it kind of gave me a very good foundation to base my knowledge on, that helped me, I guess, to kind of move forward with clinical content and work. Again, Style Italiano, their philosophy is effectively simplifying and dumbing everything down, which, like I said, it resonated with me because that's kind of how I like to learn. I really like to take the kind of complexity of things out and just keep it nice and simple. And that's kind of their sort of forte, which again helped. So with regards to after that, I enrolled on the Chris year, the Chris Orr year-long course, which is I guess, you know, really comprehensive when it comes to restorative and aesthetic dentistry, and that's kind of what I'm doing right now, which helps kind of, I guess, upskill, and then some prizes along the way, which again helps when it comes to, I guess, applying for jobs and just kind of differentiating yourself when it comes to other applications and applicants. So some tips to kind of, I guess, expedite your journey. So how do we make our kind of journey as quick as possible to transition into to private, or kind of into wherever you want to go? So the first point is, obviously you want to work out what you want. So some people don't actually want to go into fully private practices. Some people want to stay in a mixed practice, which you know, a lot of my friends are doing right now, and I can understand the reason why. You know, so first of all, you want to work out what you want and why you want that. A lot of people I know are actually doing a balance of practice and hospital as well. So again, you want to make sure that you find out what exactly inspires, or I guess kind of, you know, interests you. My, obviously, I guess, journey is mainly on how I tried to go into private practice, because I knew from an early stage that that's what I wanted. So that's kind of the focus of this particular presentation. As I mentioned in the previous slide, you definitely want to be applying for prizes during your undergrad, because that's kind of a key point to help you, or to kind of, I guess, showcase your talents when it comes to applying for jobs in a very professional and official way. So that's kind of a no-brainer. Get involved with loads of presentations, and if you can, try and actually present internationally, because again, that's going to help. Is, you know, a talking point, and it's also going to allow you to, I guess, differentiate yourself. Network. So this is kind of, I guess, what it all comes down to when it comes to finding, you know, the really good jobs. And I guess you'll be surprised at how much actually goes through word of mouth. So as a, I guess, dental student, or even as a VT, or even, you know, now, it's so essential to make sure you go to, you know, I guess, conferences or courses, or, you know, talks. Especially as a student, most of this stuff is free. So if you do kind of, I guess, pitch up and you do meet a dentist and you kind of transfer, or, you know, your information and stuff, it's really important to stay in contact, because a lot of these jobs, you never know like how they come about or how they go. So there's so many people that I know that have got jobs in a way that wasn't even, you know, a formal application. It wasn't advertised. It was just through who they knew. So you really should be thinking about kind of making sure that you're making the most of your, you know, free of a charge lectures or conferences, because as a student, it really is invaluable. And the last point, which is probably the most important point for me anyway, my experience is, I guess, you know, going to dental practices and shadowing some of the dentists that you really like the sort of work that they're doing. So let's say, for example, someone's interested in, you know, restorative dentistry or oral surgery. Find a dentist at that practice that you're actually interested in, or, you know, a practice where it might be close to home or whatever, and actually go in there and ask them if you can come in for maybe once a month or once every 3 months or something, and set up some sort of, I guess, mutual relationship where you can do something for them, and they can obviously in turn help you by allowing you to shadow. The benefit is that you're actually going to see straight away kind of how they're going to interact with their patients, the sort of way that they're doing their, I guess, dentistry, and obviously how you can essentially absorb those skills. And that's kind of what really helped me, because I was saying to some of the guys before we started this presentation, I guess one of the key points for me was the ability to kind of intern with a mentor of mine, who allowed me to kind of pitch up at the practice, watch him essentially do all of the dentistry that I really enjoyed. And that really helped me learn, because it showed me kind of not only how he communicated with his patients and stuff, but it actually showed me how he essentially, you know, talks to his nurse, and how he kind of essentially does the clinical dentistry, you know, how he actually retracts the cheek, or how he preps the teeth, what sort of burrs is he using, what materials is he using, and essentially digest all that information so I could do the same in my practice when I was obviously working as a VT. So what did I do? during VT that kind of helped me. So like VT is obviously a year where you have the ability to essentially, you know, try as much as you can within reason, right? So there's the chance to do so much clinical dentistry. So you can obviously do RCTs, re-RCTs, extractions, surgicals, the lot. And some people will shy away from that stuff, and some people will obviously grasp it and just run with it. And me personally, I really wanted to just test myself. So I essentially, you know, got involved in the deep end and tried to do as much of everything as I could. You've got nothing to really lose because you're salaried anyway. So it's not like you're kind of, I guess, you know, losing money essentially by doing so much more work. Essentially, it's a year to, you know, hone in those skills and really kind of, I guess, upskill as much as you can. So really push the boat and see how much you can do, obviously within reason, and make sure you obviously communicate with the patients to make sure that they know if, for instance, something is, let's say it's really poor prognosis, but you think it might have a shot at an RCT and a crown, try it, because that's kind of the whole point. As long as obviously the patient's on board, don't be scared, just get stuck in. I've had the whole sort of works, you know, when it came to, you know, I guess VT or doing clinical dentistry, patients said that the composite's really high when they bite it together after me sculpting it for an hour. They said, some people have said the treatment takes way too long, or, you know, some have said that the other dentist doesn't actually use rubber dam, so why do I need to? And my philosophy was that I wanted to really get better, so I use rubber dam for everything. And now using rubber dam isn't something that I shy away from because I honed in on it during VT. So you want to kind of, I guess, take those challenges, make sure you test yourself, refine the skills in VT, so that when it comes to being an associate, these things aren't a new kind of, I guess, skill set. You're effectively really good at putting rubber dam on because you've done it during your VT. And that's kind of how you're going to improve, right? You're going to really test yourself, push the boat, and see what obviously you can achieve from that. So that's kind of the key to it. Photograph absolutely everything that you can. So one of the first things I did when I started as a DFT was I printed out kind of the photography views that the BACD uses, which is available on their website. And it kind of shows you the camera settings you need for each view. And it shows you kind of, I guess, the type of, you know, photograph that you need to take in terms of how to position the patient and stuff. So I put that up on the wall, and every patient that came in, I took the whole set. Even if you didn't need them, I still took them. The reason I took them was literally just so that I could get better at clinical photography. So I had literally a ton of photographs, and I used to book out an extra like 15 minutes per patient examination just to allow that photography sequence. Now I don't book on any extra time, which is great, because as an associate, you obviously want to be making sure that you're essentially, you know, you're working for somebody at the end of the day. They're running a business, and you don't want to make sure, well, you don't want to be booking out too long of appointments when it comes to examinations. So if you're going to be adding on 20 minutes extra just for photography, that's quite a lot of time. So I thought, let me try and refine that as a VT. So when it came to an associate, I didn't need to book out extra time. And that's kind of what helped me to essentially get really well known with my my camera, and essentially be able to maneuver it quite efficiently. Invest in yourself and your equipment, and that's kind of a key. So it depends where you guys get placed for your DFT, or kind of what you do in terms of, I guess, as an associate. Some practices will have DSLR cameras, and some practices will have amazing equipment. Some practices won't. For me, I essentially just bought my own my camera. I bought some other bits, and I'll show them along the way throughout the presentation. But if your practice doesn't have it, that's fine. It's probably something that you need to invest in anyway, because you're going to need it as an associate at some point, right? So I just bought my own bits in terms of a camera, the cheek retractors, the contraster, and the photography mirror sequence, all as a DFT, because I knew it was an investment. So definitely don't be shy to kind of, you know, get those expensive pieces of kit, because they will pay dividends soon after. So the importance of photography. So photography is essential because not only is it obviously for, you know, yourself to critique your own work, but also for your colleagues to share with you. So for instance, to give you kind of constructive criticism and feedback. And also it's like, I guess, you're going to need a clinical portfolio, which we're going to go through in a minute, to show potential employers. So obviously, if you're taking photos on your camera phone, or you're using something else that's not a DSLR, it's not as clean, or it's not as high resolution, it kind of doesn't sell yourself or your own work or your skills. So you want to make sure that you have a good piece of kit, and it doesn't have to be anything too expensive. So you can get really affordable cameras and stuff. So you don't need to break the bank essentially, but you definitely do need to invest in a good quality piece of kit that can allow you to obviously not only see your work in a high resolution, but also be able to document your stuff, so you can show your colleagues, you can obviously criticize it yourself, and you can obviously show it to potential employers when it comes to applying for jobs. But I think one of the key bits that I use my photography for is essentially showing patients their own teeth, because when you actually take a photo of, let's say, a broken tooth or a massive amalgam that's got cracks in it that needs an onlay, for example, it's very difficult explaining to a patient why they need the onlay if they've never had problems or pain or anything with that big filling, and they've said it's been there for 15 years. But you see that it's kind of got ditching, it's broken, and a cusp has come off, and it's patched up with GIC. Take the photo, blow it up on the TV or the screen or whatever you've got in your clinic room, and show them, and then that straight away will do kind of the explanation, and it will just kind of do everything for you. So that's kind of a real a value or benefit of obviously having your camera. So with me personally, I didn't actually do any photography courses. I am planning on doing some in the near future, but I just want to show you guys kind of how I started and essentially where it gets to by just doing it yourself, and essentially just refining your own skills. And essentially you can use YouTube to literally see how people are taking dental photographs. So it's all about practice. So I went from here, literally, which you can see is, well, it just looks like a mess. So essentially this is the obviously lower teeth that I'm trying to take a photo of, because you can see the tongue in the middle. But I'm essentially trying to focus on these 3 teeth down here. And the 5 did fillings for this patient, and I wanted to basically take a post-op photograph. And this is kind of how it looked. So you can see, number one, I've got way too much stuff going on because I've got all of this side that I don't need. The mirror's fogging up here. You can kind of see the beard, and you can see too much that you don't need to see. And it doesn't show you what you actually want to see. The focus of the picture is supposed to be the lower 3 teeth on the back side, right? But I can see so much more that I don't need. So again, it just goes to show it all starts somewhere and it's all a mess, right? But that's fine, because it's only going to go one way. If I keep doing it, it's going to get better. So as I practiced, and obviously, like I said, no courses or nothing like that, just literally just, doing it yourself, and, looking at YouTube and other bits of bobs, and speaking to colleagues in who are older than me, who are better at taking photos than me. And you can get to a different point where everything's consistent and it's clean. And again, you're just kind of refining your skills. So for me personally, I think this showcases how everything's consistent, so it looks very professional. So if you showed a patient why should they invest in a private crown, which is 2 to 3 times the amount of an NHS crown, they're going to want to know, not only does it look better, but what's the differences. And if you can pull out your portfolio and say, this is how it's all going to look, and they can see everything kind of follows a trend, it's going to obviously do, the selling for you, essentially, if you want to call it selling. But that's kind of why I think photography is really important, because it allows you to sell yourself to patients, it allows you to sell yourself to employers, and it also makes sure that your photography is documenting everything so cleanly. So when it comes to, let's say, if you ever needed to show this for any particular purpose or documenting it into the records, it just kind of speaks volumes about yourself. So that's why I personally think it has to be consistent. So definitely invest in yourself and get yourself a camera. That's kind of the first thing you need to do out of dental school. But everyone always asks, what is a dental portfolio? And it's one of those things that everyone speaks of, but like, what do you include in it, and why is it important? And for me personally, I kind of just thought I'd share my clinical portfolio that I used to apply for a few jobs, so that you guys can get a real taster of obviously what it is. And if you guys want to take a screenshot of the page, feel free to when I put it up. It's kind of, all of the pages have been put into one page, so it's a bit zoomed out, so you might not be able to see the text, but you'll get the kind of general gist of what it is and what it's trying to show. But the importance, for obvious reasons, of a clinical portfolio is to basically reflect, so that you can obviously learn from your mistakes. we already went through why you can obviously show your potential employer, you know, the importance of that. Some jobs will ask for, like, let's say a few years experience to see, you know, your I guess ability to do certain bits of dentistry. But if you can show your skills essentially with a clinical portfolio, and you can obviously back that up with photographs, and you can obviously show them, you know, you've done 10 onlays that all look amazing, you've done 10 composites all look amazing, or whatever, they would obviously take that with, I guess, a massive sign of respect, because they can see that your skills speak for themselves. So I've personally felt like a lot of the jobs that I was looking at, they always said that they needed more experience than I have. Like I said, I only graduated in 2018, but by showing the portfolio, it's definitely helped me, because it allowed me to obviously showcase that a lot of the stuff I can do, I can actually show you, I can actually do it. So the fact that I'm a recent graduate shouldn't hinder my chance of getting a job if I can actually back it up, right? So that's kind of why I think a portfolio is essential. And we've already kind of mentioned about, you know, your patients and showcasing to them your work. So what does my one look like? So this is kind of, I guess, I just, you know, thought essentially what is it that I wanted to showcase, and how did I want to go about it. So essentially I just made it on PowerPoint and saved it as a PDF. So essentially, you know, you kind of take your clinical photos and you put them into, I guess, a presentation, and that's literally as easy as it was. It's very, I guess, mainly, well, picture orientated. I do have a few more cases, obviously, that I did include in the portfolio, but I couldn't include it onto this because of the size of the kind of screen. I didn't want to kind of make it a bit too small. But the whole purpose is, right, to first of all talk about who you are, so kind of give them a brief introduction as to obviously your background, what you've done, maybe some prizes you've won at university, or, you know, any projects that you've kind of been involved in. So that's kind of just a little introductory page, and then obviously you want to show them your work, because that's obviously the big fundamental part of it, right? They want to see what are they actually going to be investing in. So that's obviously going to speak for itself. And you can see the importance of the consistency when it comes to the photographs, because it sells you massively. And then I also found that, like, it was useful to obviously include the stuff that I do outside of dentistry, or outside of the clinic, if you want to call it that. So, you know, any committee roles or any hobbies or any other bits that you're doing. And then obviously awards and achievements, because you're trying to sell yourself. This is obviously a supplement to your CV that you're going to be sending anyway. And then the last slide is probably one of the most important ones, which is development. So you obviously want to show them a roadmap of where you're going, and what exactly are you investing in terms of courses, and how are you upskilling? Because if you're going to be joining somebody's practice, they want to see how are you adding value to their practice. So you need to obviously show how you're going to add value to yourself. So therefore, you will obviously be able to add value to their practice as well. And that's going to come through postgrad education and development and CPD and courses and all the sort of stuff there. So my 2 cents. So let's talk about, yeah, what I, just before we move on to composites, kind of, I guess, let's kind of summarize what we really wanted to mention, which is, first of all, practice clinical dentistry. So you really want to get involved, and even if it means not on patients. So it's for those that are starting the DFT, obviously in the next coming few months, and there might not be patients because of COVID, obviously, straight away for you guys to see. You want to kind of get handheld models or phantom eds and just kind of crack on and do preps, do fillings, do everything that you can. Isolate them with rubber dams and just really try and upskill. For those that are going to be in dental school, try and obviously do the same. I remember when I was in dental school, I used to go in on some days off or half days, for example, and I used to just kind of do, you know, like a prep or something on a phantom head, just to kind of get better. So again, you can obviously do that as well if you're able to on the clinic. Read and implement. So the importance of DFT, like I said, you want to make sure that you really push the boat and try as much as you can within reason. What I mean by read and implement is essentially, obviously make sure you're reading journals, articles, books, but make sure you implement it. Like, you have to have the ability to transfer that knowledge, otherwise it's just going to get wasted. So you don't want to be in that, I guess, situation where you don't develop the confidence to do this stuff, and the VT is so essential to doing that, in my experience personally. And like I said, shadowing dentists, which is essential. I felt that kind of really, you know, I guess, rocketed my sort of development, just because I was able to pick up on what these guys were doing that was so much better than me, so much more experienced, and then just essentially be a sponge, absorb all of that stuff and try and do it yourself in your own, obviously, practice. Share your cases, get feedback, make sure you're obviously developing. And obviously help others as well, you know. So that's the kind of philosophy, especially for what I mentioned at the beginning, Kaizen Dental, which is the mailing list that we're obviously going to set up. It's actually live now, but the QR code, which is still on the screen for those of you that didn't manage to catch it at the beginning, feel free to do it now. But it's kind of essentially for us to help obviously others, and also for us to learn by being involved with it. So hopefully it's a really meaningful project. So definitely join that as well if you can. It's free of charge anyway, so why not? So I'm sure instead of me rambling on a bit more about that, let's talk about kind of composites and how it works, and kind of, again, just a little bit about what I like to do. Because for me, I like to keep it simple. I want it to be predictable. And essentially, I want to make sure the patients are getting the best value for what they can of me. So essentially, the best I can do. And everything should be essentially, you know, I like to follow, I guess, you know, recipes, or kind of have a structure to everything. So how can I make everything as similar every time I do it? So today I'm going to share with you guys a technique which I learned on one of these really amazing courses, the Style Italiano course that I mentioned to you guys earlier. There are other techniques that are available, but I'm mainly going to focus on kind of, I guess, the easy one, which is called essential lines. And I've got a few diagrams and photos to kind of describe that. So composite, what's the uses of it, first of all? So I'm sure you guys already know, obviously, it can be used as a filling material for both the long term and the short term. It can also be used for a core material, and obviously for cementing onlays or bonding onlays if you want. And it can be used for obviously like a cavity liner, like flowable resin, and deep margin elevation, which is really, really helpful to get out of kind of, I guess, sticky situations, but it is quite challenging. I had kind of 2 cases this week of deep margin elevation, and it is really, really tough, especially when you come back from COVID with, I guess, all the PPE and stuff. So it's tough, but it's definitely a skill that you need to kind of get out of those sticky situations, and composite can be very handy for those. So the focus for today is obviously to talk about how we're going to use it for a definitive material, and talk about both posterior and anterior fills. So what do you really need to do before your restoration of that? Because that's kind of key, right? You want to be ready. You want to make sure that you've got everything that you need set up. So first of all, prepare your equipment and materials. So before I even call my patient in, everything's ready. So essentially, I've got kind of, I guess, you know, the LA that's kind of set up, the rubber dam kit. I've got my burrs, I've got the etch, the bond, the sandblaster. I've got it all ready to go. So there's no faffing about when the patient comes in. It's all going to be as slick as I possibly can keep it. I have my camera literally just right behind me at all times. And the purpose of that is that I kind of can spin my chair, pick up the camera and take a photo. So I don't really want to be adding on, you know, minutes to the appointment. I want it to be as quick as possible, because I don't want the patient to be, I guess, sitting in the chair for over 2 hours for me to do a composite. I try and make sure I take my time, but don't take too long whereby the patient's getting uncomfortable. So the photography stuff is, like I said, now at a point where I'm very efficient and able to just literally pick up the camera, swing the chair, take the photos, just because I've had so much practice doing it during DFT. The other key point that you should do before you start your filling, so now your patient's in the chair, before you've kind of, I guess, done anything, you want to dry the teeth. So maybe use a 3-in-1, or obviously some tissue paper or something to make sure the occlusal surface is really dry. And then you want to check the occlusion. So what have they got at that moment in time? Because it's most likely that they're comfortable with that occlusion. They've adapted to that. So you want to check the static occlusion. So the ICP, so that's when they bite their teeth together. And then you also want to check the dynamic movement. So that's the excursion. So ask them to kind of go to the left. So left lateral excursion, go to the right, do the right lateral excursion, and then go anteriorly. So check kind of how does their jaw move. And you want to check, do you have space, or where do you have space to kind of build the teeth? Or is there an opposing plunger cusp, or a cusp that's really over pronounced, that's kind of digging into that tooth that you're trying to restore? So let's say if you're doing a lower 6 and the opposing 6 has a massive palatal cusp which is digging right in, there might not be any space for you to actually do amazing morphology, or you have to make a very shallow filling to counter that. So you want to make sure you think of these things before you start, because you don't want to do what I've done way too many times, which is spend an hour doing the filling and then you spend half an hour chopping it all away, because when the patient bites, it's literally like a mountain. It's like so high. because you didn't really take the time to just check preoperative occlusion. So take that into account, make sure you see it. Sometimes you might have to adjust the opposing tooth if there's a big, let's say, for example, a huge filling on the opposing tooth. Surely it's better to adjust that one slightly so you don't have to go deeper to your filling, if that makes sense. So make sure you are prepared and check the occlusion, because that's essential. It will save you so much time in the long term. So we've got a cavity. Where do we actually start? So you can see here, this is a case where I was filling 2 posterior teeth. So these, I think this was the lower right 6 and 7. And you can see obviously they're occlusal. So it kind of is like, okay, you've got the anatomy there when you start, but let's say you've taken it all away and you kind of get lost and you think, what do I do next? Or how does it work? So it's really difficult when you don't know what you need to essentially recreate. So the first thing that we need to do is actually learn our anatomy, okay? So what I always suggest is, like I did at the beginning, go to Style Italiano on the website and just look at their anatomy, which is really easy to understand, really simple, and it's called what they call the essential lines. So it's literally a few scribbles, and for each tooth, you can essentially, relay that to the real deal or the real clinical situation. So you want to learn your fissure patterns because you need to know what you're going to be creating. Because if you're in a position where you've got, let's go back to the previous slide, if you've got this and you don't know what you need to create, there's no way you're going to get there. So you can't just kind of guesswork. You need to know, first of all, what is it that you're going to be recreating. So the first thing I would do is really go to this website, have a look, print this off, and essentially learn the anatomy. It's not really that hard. The 7 on the bottom, you can see is a hot cross bun. This, again, a few squiggles that you'll be able to replicate after a few times of actually looking at it. And again, the other teeth, it's the same thing, and it's always the same. That's kind of, like I said, I want to keep it as simple as possible. So now let's pretend we've learned our anatomy. So you guys know everything now. Now it's just about how do we do it in the actual case of having a tooth that's got a hole in it. So you've got the hole, as you can see on the left. The first thing you want to do is orientate yourself. So essentially work out where you're sitting, or where exactly are you, I guess, needing to fill. So as you can see on the photo on the right, the bits that are purple is essentially the remaining outline of the fissure pattern. For this is a lower 6, so this is a lower first molar. And you can see that there is some remnants of remaining natural tooth structure. So you can see the lingual fissure here, you can see the mid-buccal fissure, the distal buccal, and again, this is all kind of the vacant cavity that we need to fill. So we know exactly where we are because we can see the remaining tooth structure. So first step, orientate yourself. So if I show you one of my cases and how we did that, so we got from there to there, but the first thing we did is orientate ourselves. We worked out exactly where we are. The other good point I have for you guys is it's really easy once you've done this to think, okay, let me just join the lines up using the essential lines and I should be able to get to the end result, right? But sometimes, again, I've done it, you can go off center. So sometimes you can actually go a bit too far this way, and these two cusps are way too small and these cusps are actually way too big. So how do you counter that? So you want to use the tooth in front as a guide, because you can see this is unrestored. And you want to basically allow yourself to follow the midpoint of this tooth, because you want to make the midpoint of your filling in line with that. And again, the same with that one. So if you're able to do that, you should be able to get the occlusion fairly correct and the aesthetics fairly correct, because if you're going to follow obviously your essential line pattern, using that midpoint, it will act as a reference. So that's kind of the first tip that you want to do. Okay, so I made sure that when I did my essential lines, it went in with the midpoint of the 5, and then I translated that to the 7 as well. So that way the 6 and 7 followed that same line. Okay, so again, same as what we said before, learn the anatomy and plug it in. But it's really easy for me to say that because obviously, it is literally that easy. You just learn the anatomy, but let's go through the step by step. So let's start when we've got a cavity. So you guys can see on the screen, this is a screenshot again taken from Style Italiano, so definitely do go back to the site and actually look at their content. But this is, I guess, a cross section of a lower molar, and you can see it's an MOD cavity, so you're essentially missing the distal, the mesial, and the occlusal surfaces. So the first thing you want to do is, once you've done your etch, your bond, and everything, and you're ready to fill, is you want to assess the residual cusp angulation. So you can see the dotted line that's shown on the screen there. You want to see how steep, or I guess what tooth structure do you have and the angle that it comes in for you to obviously do your filling. Because if you can see my cursor, this line obviously follows kind of, I guess, it's a tangent to obviously to this area here. So if, for instance, you were to do a filling, you want to make sure you follow that line so it's not too high, because if you come off here, it's going to be way too high when the patient bites down. So what you want to do is you want to assess the angulation, and you want to identify the cuspal slopes that you need to recreate. Okay, so that's the first thing you want to do. Have a look at what you've got left, look at the fissure pattern, and also have a look at the remaining cusps and work out their angulation. Okay, once you've done that, let's say you've filled up your cavity, and you always overfill because you want to make sure you condense it nicely so there's no air voids, there's no sort of, you know, bubbles, air bubbles or anything like that. So you want to really compact the composite nicely. So really work at it with, you know, either micro brushes or brushes, or kind of, I guess, pluggers, whatever you're using to do your composite. So let's say we've filled it all up. Now we still want to have a look at this angulation of the cusp, because if you look here, the white, which is all the composite that we've placed in, is way too high, right? The patient bites down, this is going to be way too high in all of these areas. So what you want to do is you want to start carving. So what I like to use is an instrument from the LMArt kit. It's called the condenser. I'm sure many of you guys will probably have this already in your restorative kits at uni. But you basically take the instrument, and it's got two sides to it, okay? It might not be the same instrument that you have, but there's probably instruments out there that are pretty much the same design. So the first thing you want to do is, obviously you haven't cured your composite, you've overfilled it, and now you've taken your instrument and you've essentially got two ends to it. One end will be able to go onto one cusp, and the other end will go onto the other cusp. You can see half of the instrument actually sits on the cusp, and half of the instrument will sit on the composite. And the reason why that's important is because as you use the cusp as a guide to move forward and back, you're going to be actually recreating that sort of height into the composite. So you're basically going to literally rest the instrument onto the cusp and use that to actually go forward, back, and remove the excess composite, but recreate the same incline into your own composite so it's not too high, okay? And that ensures that the composite is at as close of the right angle as it can be. And you might need to obviously do minor occlusal adjustments, but it's not going to be super, super high. So that's the first thing that I like to do. So I overfill, and I basically rest the instrument onto half onto the cusp, half onto the composite, and just go forward, back, and remove as much as I can without overdoing it, okay? Once that's done, now I've essentially got the composite at the right, or as close as I can to the right height. Now I want to make it look a little bit nicer. So what I will do is I will take my next instrument, and this is essentially a sharp-ended instrument, which could be like a sharp probe some people will use. And essentially what you want to do is, using the same protocol that we just discussed earlier about the essential lines, you literally want to draw the fissures into the tooth. And you do the same as what you did before. So you look at the remaining sort of tooth structure, what fissures do you have, and what do you need to recreate? You want to look at the tooth in front, or maybe two teeth in front, and you want to assess their midline, so that way you can obviously recreate the right midline in your composite rather than going off center. So that's kind of how you're going to get it. And you can go from the top photo like you see to the bottom one. Again, that would not take long at all. Okay, so it's essentially very straightforward, very easy to do. Follow the teeth in front for the midline so that it's all in line. And you literally want to just do the same steps as what we said before. So you use the remaining tooth structure to check, I guess, the fissure pattern, and just literally copy and paste from what you know. And then you can get a little bit fancier, and you can obviously do, you know, secondary anatomy, and you can stain the fissures. And you can kind of, I guess, take it one step further, which again, it depends kind of, I guess, how much time and obviously how much effort you want to put into it. Staining is something that you guys probably would have seen on Instagram and I guess other social media platforms and stuff. Staining, I guess, you know, it obviously makes the teeth look a little bit more, I guess, 3D, and I guess the anatomy is a little bit more pronounced, which is lovely to see. It obviously can mimic the adjacent teeth quite nicely as well if they are stained. But essentially the staining is kind of very lightly filled resin, so it can fill, I guess, the micro porosities that you might have in the composite that you've done. So it is beneficial in that sense, but it's not kind of, you know, going to change the lifespan of your composite. Essentially, it's just going to make it look a little bit nicer, and it means you've light cured your composite a few more times. So essentially, it's, I guess, fully cured, if you want to say that. Now, that's kind of class 1. Let's talk about class 2. So class 2 composites is basically where you're missing, I guess, a proximal wall as well. So you've got a mesial or a distal or something that's missing, and you need to restore both the MO or you know, an MOD, for example. And the common questions that, for instance, I had and I commonly get asked is, how do you make sure you get the right size height for the marginal ridge? Because when I was doing it, even sometimes now, it's way too high. So you need to kind of, I guess, have some tricks up your sleeve to know how can you get it to the right size. And how do you get the right contact point, which is essential, because you want to prevent things like food packing, and you obviously want to make sure that the patient's quite comfortable, so it's cleansable. How do you get the right anatomy, which again, we've just run over, but we'll go over that once again. And what order do you place your band, because that's quite important. So that's kind of the matrix system that you're using. So there's different matrix bands out there already that I'm sure you guys would have seen and had some experience of using. On the top left, you can see, which is called a sectional matrix, and that's the Dentsply V3 system, I think it is. And that's where you have like a ring, a metal sort of band, and obviously a wedge that you have to put together. And on the right side, on the top, you can see a circumferential matrix, which we commonly use. And it's kind of really obviously useful for things like amalgam and placement and so on. But you need to work out what's the differences between the two. So the first thing, I guess, which is really different is obviously one's easier to use because it's so much quicker, because you put the omnimatrix or the circumferential band on and you wedge it and it's done. Whereas the sectional matrix is 3 separate bits. So it's a wedge, the band, and obviously the metal strip. And you need to make sure it's adapted properly, and it's a little bit more, I guess, fiddly at the first few times that you're using it. But the main benefit, as you can see on the X-ray on the bottom, is the anatomy that you can get when you use the different bands. So the Toffelmeier, which is, I guess, the circumferential band, is very, very straight. So the contact point that you're going to get is going to be straight, okay? Whereas here with the sectional band, because it's got a bit of a curve, when you're using it, essentially it's going to try and give you that natural bulbosity of the tooth that you would want. And that's going to help, because you can see that this little, I guess, space here is a lot less than this space here, which is going to be things like food packing and stuff might be a bit different. It's not really that big of a deal, but I think a lot of dentists will definitely endorse using the sectional band over the omnimatrix for the majority of their class 2 composites. And it definitely does help, I guess, get a better anatomy when it comes to resembling the natural tooth. So how do you place it? What's the order? So like we said, it's 3 separate steps. The way I do mine is I put the metal band in first. So that's kind of the metal, I guess, small kidney bean shaped matrix. You put that in first, and you want to make sure you get really good adaptation. And then you want to wedge it so it's kind of held firmly in place. And then you take the final piece, which is on a piece of forceps, and you put the blue ring on, and you kind of, I guess, wiggle it down so it's fully engaged and it's nice and tight. By doing that, you've essentially created, I guess, a platform or a scaffold for which you can condense your composite against, and it should hopefully resemble the nice natural contact point that you're looking for. But once you've done that, what's the next step? Because now we've obviously got everything ready. We've done our etch, our bond and everything. And how do we get to the next step, which is to try and get a really nice looking composite? So the way I like to do it, and I'm sure a lot of dentists that you guys would have seen their work do it a very similar way, because I've probably learned it from most of them, is you want to basically get the marginal ridge done first. So you want to turn it from a class 2 into a class 1. So build up the marginal ridge, build up the mesial wall, for example, in this case. So that way you've now created a simple occlusal composite only left to do. You've done the mesial part. But now we need to make sure we get the right height. I don't know if any of you guys have seen this instrument before, but as you can see on the screen, the blue over here is the composite. The little band in between the teeth is the sectional band. And this thing here is actually a particular instrument called the LM Art Mesura, okay, which is a really cool instrument. And it essentially, I guess, like we said, what the Style Italiano guys like to do is make foolproof and easy to, I guess, copy methods. Essentially allows you to work out what your marginal ridge height is with very minimal thinking. And the way that this does this is because it's got two, I guess, prongs to it. The first piece in the middle, it essentially rests where the sectional band is. So that will obviously allow space for your sectional band. Now, the prong in front will go onto the adjacent tooth, and it will essentially stop at that marginal ridge. So that way your composite, which is uncured, you will actually create the same marginal ridge height by obviously copying this particular marginal ridge. And once that's done, you just move left and right to make sure you scoop up all the excess composite, and then you can light cure it. The benefit of doing it this way is that you've effectively copied the height of the tooth in front into your composite, so it's going to be as close to the natural, obviously, occlusion as you can possibly get. Again, you might need some minor adjustment, but you're trying to minimize that, okay? And that's the whole point. So once we've done that, you, like I said, have a class 2 that you've converted into a class 1. So that this particular wall, I made it just doing the exact same step I just explained. I wedged it, I obviously put my band and everything on. I used the LMArt Masura instrument, and I essentially went right, left, copied the marginal ridge height of this particular tooth, and that way I got my new composite at a right height. And you can see there's absolutely no high mark on this area, so therefore it fit the occlusion perfectly. A useful tip is make sure that you do not remove your wedge whilst you're doing your composite, because your wedge is basically placing pressure onto the gums. And even if you've got a rubber dam and stuff, by placing pressure on the gums, if you remove it midway through your composite, there's a high chance you're going to get some blood seeping through. And that's obviously going to contaminate your bond and obviously your moisture control. So you don't want to do that. You always can take out your matrix band and you can take out your ring, but don't take out the wedge. Okay, always leave the wedge. There's no benefit of taking the wedge out because it's not in your way. So the only thing is it's going to cause it to obviously bleed. So don't do that. Now, another benefit of doing this particular filling this way is that it allows you to stop halfway. Okay, so because you've made your wall, you've got time now to assess this. So assess this from the side, take your mirror, have a look and see, is there a void somewhere? Is it not right for one particular reason? And if it is, drill it off and do it again, because that would have only taken maybe a minute. So instead of doing the entire filling and then realizing at the end that you've got a void or you've got something that's wrong with the filling, you've essentially clarified that issue by obviously stopping halfway once you've built your proximal wall and reassessing. Okay, so that's really, really useful. Now, I did want to very quickly just run over before we move on to the anterior teeth, which is a little bit more exciting, about kind of the stamp technique, which I'm sure you guys might have seen on social media and stuff again, because it's quite widely available. This is kind of, I guess, literally a copy and paste method. It saves a lot of time, and the benefit of doing this is essentially if you've got a non-cavitated tooth, you can copy the anatomy preoperatively and paste it into what is the now post-operative result. Okay, and the way it works is you want to basically, I guess, take a microbrush and a little bit of flowable resin, and you want to place the microbrush onto the occlusal surface, as you can see in the second photo, and then place a little bit of flowable all over that tooth and all over the microbrush, so the two kind of, I guess, are engaged, and then light cure it. Okay, what you've effectively done is you've created a stent of the actual unrestored tooth. Although it's got caries, it's non-cavitated, so it would have shown on your x-ray that it needs a filling, but it hasn't broke through that that layer, so therefore you can actually copy and paste. Okay, so first we've copied it. So now we've light cured this particular microbrush, which has a bit of flowable resin on the tip. Keep that safe. So you just put it on the side and don't touch it until you need it, which is going to be in a few minutes. Remove your caries, which you can see in the third photo, and do your bonding protocol. So, you know, air abrasion, so a bit of sandblaster, or then etch it and use your bonding, you know, kind of bonding agent that you're going to use, and get ready to place your composite. Then what you would like to do is you'll take your composite and you essentially place it into the cavity, and you would just kind of condense it quite nicely, and make sure you overfill it a little bit. Just like I said before, you want to make sure that there's no sort of voids. So when you're condensing it, you compress all the air out. Then You take a little bit of Teflon tape, which is the white tape that you see on the screen, or PTFE tape, as you guys might know it, and you place it over the tooth, okay? The composite's into the cavity. It's not cured. It's just been condensed a tiny bit, and now you've basically placed a bit of Teflon tape over this tooth that's got uncured composite in there. Then you pick up your handy microbrush that's got a bit of flowable resin at the end that we already made preoperatively, and you press down, and that way you've basically put on the pressure onto the actual tooth and pasted your anatomy. And now the Teflon tape is acting as a, I guess, barrier, because if you didn't have the Teflon, your microbrush would now stick to your new composite. So therefore it would kind of be pointless. The Teflon has to be there. And you can see on the second from last photo, the Teflon tape is obviously, you know, got the imprint already. So you know that your end result's going to look pretty decent, because obviously you can see that you pasted the anatomy. And now if you look at your post-op, obviously at this point you would have light cured and everything. You don't remove the Teflon until you've light cured and everything like that. So you've light cured, you then remove the Teflon, and you can see that you've obviously repasted now what you had preoperatively, and it looks great. So that now will make sure that the occlusion's not high. The tooth looks obviously great because it's what it was naturally. And obviously because the occlusion's not high, you're so much more efficient when it comes to just doing this whole procedure. And it's kind of, I guess, an easy way to do this. So we'll go over some anterior cases, and then we'll take some questions. Okay. Anterior composites, like I said, this is a bit more exciting than probably the posteriors, but I do enjoy my posterior as well. But I'm going to try and keep it simple and just go through, I think, one or two cases, because it can get quite complicated. But I will be sharing a lot of my cases via the Kaizen Dental platform, and more importantly, how we did what we've done and why, so that you guys can understand the reasoning behind it, because that's kind of the whole point of sharing content the way we want to share it. So the first thing that you need to do is obviously get your shade. So shade is a really important concept, but it's not the most important, okay? Shape is actually proven to be more important than the shade, but you've got to have a relatively close matching shade to make sure that the end result is going to be pretty decent. So that way people don't actually notice that the tooth is obviously not a natural tooth, right? So there's different ways of taking a shade, and we're just going to kind of talk through the different ways. So the photo on the left that you can see is what we call the composite button technique. So the composite button technique is basically where you place some composite shades that you're going to plan on using, or maybe you're thinking about using, and you essentially place them onto the tooth and light cure, okay? The whole purpose of this technique is to work out which composite shade closely resembles the tooth structure that you can use to obviously recreate that I guess, that natural part of the tooth. Now, the positioning of these composite buttons are quite important, because obviously if you position it in the wrong place, you might take the shade as a reference from the wrong place. So what we normally say is you want to place the dentine shades if you're using a dual shade composite, so a two shaded composite, which means you have a separate dentine shade and a separate enamel shade, and you put them together and they basically make the obviously the end result. You want to basically take the shade for the dentine at a different position to what you want to take the shade for the enamel. Okay, I hope that's clear, and if it's not, just let me know in the questions or the chat area, and then we can obviously go through this again. But basically, as a reference, more cervically, so at the neck of the tooth, there's more, I guess, dentine in this position and less enamel. So there's more chroma to the tooth, okay? And that's why we want to take the dentine shade towards the neck of the tooth. So this shade here is more likely going to be the dentine shade, so it's taken higher up. And in the mid body, there's more enamel, or at the incisal, there's more enamel. So you want to take the enamel shade from this position. And that way, you're basically referencing the dentine shade towards the neck of the tooth, where there's more dentine, and the enamel shade towards the mid body or the incisal, where there's more enamel. And you can take, again, an incisal shade to work out if there's any effects. So by effects, I mean things like, you know, halo or incisal halo, or mamelons, or anything that's kind of, you know, unique to that particular tooth that you want to recreate. Now, you have to light cure. That's so important that you have to light cure when you take these shades. You can't just place them onto the tooth and take the shade, because by light curing them before you take your shade or have a look, you have to make sure you account for something that's called polymerization shade shift. Okay, so that's basically where the actual composite slightly changes color, very slightly, once it's been light cured or polymerized. So what you don't want to do is take the shade when it's unpolymerized, so unlight cured, and then you actually do the treatment and you realize at the end it's actually different to what you thought because there was a little bit of shade shift. So make sure you light cure to obviously to get to have a look at that accuracy of the shade. You do want to take a photo of the shade tabs or of the composite buttons on the tooth. The reason is because obviously you can assess this at a later date, and also you can do some effects, which means I'll show you in a second, but you can look at a black and white photo and you can work out the value of the tooth, so kind of how bright or white it is, and you can look at the chroma, so you can do a highly saturated photo and work out how I guess saturated and how much dentine there is, and we'll show that again on the next slide. But before we move on, what I like to always mention is the photo on the right is what we call a custom shade tab, okay? And this is probably the best way to take your shade. So a lot of us at this moment in time, we're using kind of Vita shade tabs, which is kind of the most popular thing to use to take a shade of the teeth. But the thing is, what we need to remember is the Vita shade tab, number one, is a bit of kind of acrylic. So it's different to essentially the tooth that you're taking, obviously, the shade with. And a lot of composite systems are not, Vita compatible. So that means their shade is different to what the Vita shade guide shows as an A1. So some systems A1 is not actually Vita A1. So therefore, if you take, let's say, for example, let's just use an example of a composite as Filtech. If you use Filtech, it might not be Vita compatible. Therefore, if you use that particular system and you use a shade tab, and essentially you realize that the A1 in their particular system is not the same as the Vita A1, and therefore it's not being representative of taking a shade. So what a custom shade tab is essentially you make your own shade tabs. So you use your own composite system, and you essentially light cure it, and you can use the enamel and the dentine shades. And by doing that, what you've done now is whenever you take the composite shade tab to the tooth, whatever matches most closely is going to be whatever your composite is, right? Because it's from that system. So therefore, it's going to be a very, very good or highly accurate representation of your final end result. So custom shade tabs is really, really useful tip. And there are some kits out there that you can get. I think the most common one is from OptiDent. It's called My Smile Line. Again, I can mention that again at the end if anyone's interested, and we can talk through that. So, like I said before, you want to take some photos. So by taking the photos, it's really important because you can do some effects. So your camera, obviously, once you've taken your photo, you can convert it to black and white. And by doing black and white, you can work out the value or the brightness of the tooth. So you can work out how white it is. And that really helps because it can obviously show you things that you might not see with, for instance, the naked eye, or for instance, just a normal colored photo. Second thing is you can obviously get it highly saturated. So this is the same photo, just some more effects put on. And by doing it highly saturated, I can work out the dentine saturation, how much chroma, how much yellowing, or how much shows through, and where is it most prominent, because I need to recreate this. So for this particular case, it was a diastema closure. So I was closing up some of the gaps that you can see, but there's different shades to the tooth. Like incisally, there's a bit more kind of blue or gray tinge because of the incisal halo that's there. You can see some mamelons in the inside. And again, you can see it's so much more yellow at the neck than it is kind of around the tips. And again, that's important because you want to work out and get as much information as you can. So definitely take some photos and change the effects. So you literally just change it to black and white and change it to saturation. You can even use, I think, your iPhone to kind of do these things. So if you actually sync it to your iPhone, your camera, you can actually do this sort of stuff. So it's quite straightforward. So let's go through some cases. So this is a particular case that I did during VT. So it was a lady came in and she didn't like the stained composites that she had in between her teeth, and class 3 composites, so that's kind of interproximal composites, are always quite challenging because I guess, you want to work out, number one, how do you do it without removing too much tooth structure? But at the same time, you want to make sure it's kind of aesthetic. So you want to be not taking away too much, but taking off enough so that it gets a good end result. And it's really important to find that balance. So I'll show you how I do it and how my thinking is behind it. So hopefully you guys can obviously see. So the first thing is obviously you obviously do your local and get everything ready. Once the rubber dam's on, which I always try and use if I can, a rubber dam, just because it makes life so much easier when it comes to working. You don't have to kind of retract. There is no retraction essentially because everything's been retracted for you. For the photos as well, it allows you to have consistent photography, but also it ensures that you can kind of see the adjacent teeth quite nicely. So therefore you can try and recreate the anatomy as closely as you can. So let's have a look. We obviously took out the filling. I don't know if it's that clear on the photograph because it's kind of been, I guess, shrunk a little bit. But when you've removed the caries, you need to work out, do you need to do a bevel or do you not? Okay. A bevel is basically where you're trying to essentially, I guess, remove a little bit more tooth structure so that you can ideally create a really good aesthetic result, okay? Because there's, I guess, more surface for the composite to bond to, and you don't want to get that junction or that line where you've got obviously a composite and you've got tooth, and that's kind of where the bevel comes in handy. Now, before I show you the next photo, this is the cavity prep that you can see, okay? If you can see my cursor, you can see that the upper right one, it's there's no bevel there, okay? So it's just literally the caries have been removed and there is no bevel whatsoever. It just stops at that junction. Whereas the upper right two, the caries in the composite, well, the composite's been removed and there's a little bit of caries underneath which we took away, but we have done a bevel. Now, why did we do one for one tooth and not the same for the other tooth? Because they're both class 3 composites. So why would that be important? Now, for me, obviously, I want to be drilling as little tooth as possible, and there has to be a reason why I do it. So for the upper right 2, you can see that the composite is a lot bigger, okay? Now, the existing composite is already a lot bigger, but it actually goes into the line angle of the tooth. So the line angle is basically where the proximal surface and the buccal surface meet. So that's basically where light reflects. So you can see here, this is the line angle of the canine because that's where the mesial surface comes around and the buccal surface comes there and they meet. And that's where when you take a photograph or something, light reflects from this point, and that's called the line angle of the tooth, okay? Now, for this particular tooth, this cavity comes into the line angle of the tooth. So that means I have to do a bevel because if I don't, when light hits this, there's going to be a line showing there, okay? So that's why I did a bevel for this tooth. But if you look at this one, it's so much smaller. So when I actually took the composite out and removed a little bit of the caries, the line angle was here. It's so far away from actually where my cavity is. So because they don't impinge on each other, there's no need to do a bevel because it's not going to give me any benefit aesthetically. I'd just be removing more tooth for no reason. So that's why my cavity prep is calculated. I've thought through why I'm doing it, okay? So now I've got my cavity prep, and like we said, we do our sandblasting and our etch and everything, and we've got it ready to bond. We need to bond it. So I did, before, I'm showing you obviously the upper right 2, but before I did the upper right 2, I just filled the upper right 3. I did that freehand because it was easy to access. So I didn't use any matrix bands or anything like that. I literally just put a little bit of composite onto a flat plastic, and I effectively condensed it, and then I went over it with a micro brush. So that one's filled, okay? And I trimmed it down with a soft flex to make sure I had enough space for the upper right 2. Now, to do the upper right 2, I've used a mylar strip or a Hall matrix or whatever you want to call it, and that's basically one of those see-through matrix bands that you basically put through onto the palatal. So it's gone through the mesial and the distal, and I've basically got excess palatally, obviously, and the whole point of that is to I guess have a platform to build my palatal shelf or my palatal wall, okay? So I place a little bit of composite again with a micro brush, and you just essentially, I guess, press onto the mylar strip with your finger going palatally. So that way you're putting pressure in it on the tooth from the palatal direction, and you're pressing your composite from the buccal direction. So that way you've essentially compacted the composite quite nicely. And before you light cure, what I always like to do is I like to remove the excess. So that way I don't have ledges. I always try and minimize the amount of work I have to do at the end because I'm quite lazy. I want to make sure that it's not too much going on towards the end. And besides, like I said, I don't want the patient to be sat in the chair for too long. So what I will do is I'll take a probe, or I'll take something that's like a sharp, fine instrument, and I'll remove the excess, which is going to be around here of the tooth. So for example, here, there'll be excess composite there. Just remove it, flick it off when it's uncured, because it's easier to do it, and then light cure it. Okay, now it's light cured. I've got my palatal wall. I need to do my mesial and my buccal. Okay, so for the mesial, I don't have a photo of that one, unfortunately, but what I did was I placed one of those posterior bands that we saw before, the metal matrix bands, and I just put it into the tooth against this particular point here, and I just pressed some composite against it, and I built that proximal wall. In the end, this is what the composite looked like. This was during DFT, so it wasn't using any fancy composite systems. It was I forgot the name of the composite. I've never actually used it or heard of it until VT. I forgot what, for the life of me, I forgot what it was, but it wasn't anything kind of fancy. It was the composite we used at that time anyway for what the practice said as the NHS composite. So it wasn't anything kind of too flashy. But you can see you can still get really good results because you've calculated everything. You know, you've worked out where do you need to do your bevel. This one, we said it comes in the line angle. So therefore we have to do a bevel because it's where light bounces, we don't want that margin visible. But you can see here, the line angle is the same as it was pre-op. The composite doesn't impinge there, no bevel, no need, okay? Saves the tooth, obviously some drilling, but also it makes sure that your result at the end is gonna be quite nice. Because you can see this particular composite, she didn't want changed, which she should have, because it would have made everything look a lot nicer. But you can see the differences between the two. This one should have had a bevel there, really, and the composite shade's a bit off because it's stained over time, which it obviously does. But it just goes to show kind of, I guess, you know, if you think everything through, there's no reason why you can't get a good result. So let's go through another case. Okay. This was a tough case, this one. This was a girl who came to see me because her ortho that she had before in the past, it kind of relapsed. She didn't want ortho again. And it really was an ortho case that she should have had because the result isn't going to be as great. Obviously, it's quite tough because the teeth kind of inclinations are wrong and the positioning's all off and it's kind of all a bit of a mess. But there's a lot to improve on the end result, which I'll show you in a minute, and the steps. But it's, I guess, something that we can still do and get a good result that she was happy with, at least anyway. So what I did first was so she only wanted her two front teeth, the gap, so the midline diastema closed. She didn't actually want the other teeth bonded to, because you can see that the laterals are quite small in comparison to the centrals. The centrals are really dominant. So she didn't actually want to have these built up or bulked out, which I think she should have had maybe at least the front 6 done if she wanted the ideal result. But anyway, she only wanted the midline done. So what did we do? The first thing I did is I basically took some measurements. So there's a black Sharpie line on the rubber dam that you can see in the middle. And the purpose of that is actually to work as my reference, okay? So what I've done is I basically essentially measured the midline diastema, and it was 4 millimeters. So I worked out, okay, the midline diastema of 4 millimeters, she wants 2 teeth bonded to. I knew that I had to add 2 millimeters to either tooth. Okay, and I marked that onto the middle of the tooth as a reference for me. So I knew that that's where I have to stop, because if I went way beyond that, the one tooth would be bigger than the other and it would just be a bit of a mess. So draw the midline onto the rubber dam so you don't go off the center. Then what I do is I took a mylar strip and I placed it palatally and I put a bit of pressure with my finger and I basically built the palatal wall very thin. It was about 0.5 millimeters thick. And I essentially made sure I didn't go beyond that midline, that black Sharpie pen. I didn't want to go into the next tooth's restorative space because, like I said, it would make one tooth way too big. Now I've done that, I've light cured it. So now I need to do the next bit, which is the proximal wall, the mesial bit, okay? So what I will do at this point, you can see that the reference point is still pretty close, resembling the where the matrix band is. So this is the posterior matrix I was talking about before, which you basically place it kind of, I guess, instead of horizontally, it's vertical now. And that way it's going to give you a really nice sort of mesial wall. And that's exactly what I used for the previous case that I didn't have a photo of, but it's the same concept. So you've taken the matrix band, you've placed it against the tooth. You want to make sure you tuck it in as tight as you can underneath or into the embrasure space, because it should hold itself. If it doesn't, you can wedge it or you can hold it with your finger, okay? Now, once you've done that, you're effectively holding it. In my case, with my left hand, I'm holding the matrix band in place, and my right hand, I'm basically going to be packing the composite. So what I will do is I'll pack the composite, and I will now create a wall. Okay, again, it's very thin. It's about 0.5 millimeters or so thick, just because this is the enamel shades that I'm working with, and I try and keep my enamel shades at a 0.5 millimeter thickness, which is the kind of, I guess, thickness that people are essentially endorsing when it comes to, you know, the systems to make sure you've got the right sort of effects and thicknesses of your dual shade composite. Now, once you've done this, what you've effectively done is you've created the outline. So I've created my palatal wall and I've created my mesial wall. So now all I've got left is the buccal. So what I will do is I'll take my composite and I'll place it buccally, adapt it really well, and I'll use some brushes, I'll use some wetting resin, and I'll really condense this composite as nicely as I can, because I want to minimize any sort of post-operative sort of work. And you can see it's quite a big tooth there, but you do essentially the same thing for the upper left one. So same as what you see at the top here, you take the mylar strip, you do the same thing, take the band, and you do the exact same thing, and you have two teeth that are done at the end. Okay. The finishing and polishing is a little bit complicated, and I will go over that in some of the sort of tips that we're going to be sending out on the, I guess, Kaizen Dental mailing list. But essentially what you can do is get to an end result where you've taken her from this position in about an hour and a half, 2 hours or something, to this position where she's essentially closed the gaps, and you've tried to disguise it. You can see this tooth is coming a bit further out here, and you've disguised it. This case is the same technique that I've used for numerous diastemas, because it saves me having to have any lab work, because I don't need a diagnostic wax up, and essentially it's you know, a relatively straightforward way of doing it. And there's so many cases that I've done like this, which again, it is quite helpful. So before we take some questions, I will just again let you guys know about what we're doing. So if you found any of this sort of stuff useful, feel free to, I guess, sign up to what we're offering, which is free of charge content sent straight to your inbox. When you sign up, you will get a PDF that's quite detailed about a bonding case, and you know, show you some, I guess, content about color and understanding a few different bits. And it's essentially aimed at, I guess, young dentists, DFTs, and so on. So it's free of charge, so feel free to sign up. And this is an example of some of the content that we're going to be showcasing, so that you guys can obviously see. And again, this is the code and everything. It's all for free, so feel free to jump on. And then, yeah, that's kind of it. And I hope it's been useful. I know I've probably spoke for a fair bit of time there, but
no, that was really helpful.
Yeah, good. I'm glad.
Yeah, that was really good.
Good stuff. I'd love to take some questions if there are any, but I'm glad that it was useful.
I'll have a look at that. Yeah. So we've got a question by Ibrahim, and he's asked, what do you use to prevent composites from sticking to instruments?
Yeah, really good question. That commonly happens. I know when I was at uni, I remember we used to use the bond, and we used to put it on the instrument to basically prevent it from sticking, which worked. But the thing is, don't ever do that, because the bond actually has like HEMA in it, most commonly. And if you're going to be dipping your instrument in HEMA, like a bond, it's going to stain the composite over the long term. So don't do that. What you need to do is basically buy some wetting resin. So that's actually what it's called. It's called wetting resin. And the one I use is by Signum. So that's SIGNUM. And what it does is, like, you can basically dip your instruments or dip your brushes, for example, into it very lightly. And what it does is it prevents the composite obviously sticking to your instruments and stuff. And it also allows your composite to not have as many streaks or voids in there, which is really useful because it reduces post-op kind of polishing and stuff like that. Again, that's kind of a really, really useful piece of kit that you want to be investing in.
Nice. I've been doing that. My tutor told me to do it, and I've been doing it since day one.
Yeah, that's exactly what we were told as well. And then we realized that it's not great for the long term of the composite, because it stains the composites over time. So yeah.
Someone's asked, how do you prevent composite from dragging?
So that's all kind of, I guess, a combination of using a bit of wetting resin, because you want to make sure that it's got a little bit of flow to it, so that it can obviously be adapted quite nicely. But you also want to make sure you're compressing the composite really, really firmly. Okay, so first of all, you want to make sure you're actually putting pressure onto it, so that you're reducing the air voids in the composite. That's number one. Number two is like using wetting resin, that helps. Number three is you can heat your composite. By heating it, you basically, I guess, increase the ability of it to, be maneuvered around. And that way you shouldn't get as many sort of grainy bits in your composite, because it half cures or whatever, which I'm sure a lot of us have had that problem. So if you're able to heat it, that's great. So, if you can't invest in a composite heater, you can actually buy what I did in VT. I bought a coffee mug warmer, which was like £3 off Amazon or something, and I just put my composite onto that in the little compules, and it heated the composite enough for me to I guess get going. But there is a bit more science behind, obviously, the right temperature and stuff. But as a VT, that's kind of what I use now. I've actually got composite heaters, but yeah, that's kind of a good starting point at least. So that's really useful to do to prevent you getting those drags.
Okay, thank you. Got quite a few questions coming in as well.
Good. That must mean the PowerPoint wasn't clear enough then.
No, don't say that. Someone's asked, does the sharp probe-like instrument you use to create the fissures have a specific name?
Yes, it does. So if you guys go into Google, you'll be able to find the name of the kit. It's called LM, and then it's the second word is art with an E, so ARTE, LM art. And it's kind of, I guess, a set of 5 instruments, or 6, I think. And the one that I was referring to, which is, let me get it back up so you can see a photo of it, just to make sure you get the right one if you are going to buy it. It's called the Fissura. So basically, on one end, it's got like a sharp tip that you can see there, a bit like a sharp probe, but it's got a bit of a curve to it. And the other point is like a cone, and it's got a sharp tip there as well. So that way you can kind of do the fissure pattern, but also the cuspal sort of anatomy as well with both tips. So that's really, really a useful instrument. It's probably a game changer for me anyway. So yeah, that's kind of called the LM Art Kit. It's LM ARTE, and that's the Fissura, FISSURA.
How did you get the confidence and skills to all that amazing aesthetic work in DFT?
So what was the question? How did I get the confidence to do this?
The confidence and the skills to do all the aesthetic work in DFT.
So that's a really, really good question, because it's one of those things that you only really learn by obviously doing. So for me personally, I've had everything that you can probably think that you will get when it comes to, I guess, patients saying the composite's high, the composite's the wrong color. I still, there's times like I did a case pre-lockdown, a bonding case where the patient was like, she doesn't like it, the teeth are too long. It happens all the time, but you've got to obviously do the work, make sure you do it properly, and obviously you know that you're going to fix it if worst case scenario something doesn't come out right, for instance. But obviously don't take like crazy risks and go in and do composite veneers, and all this other stuff as your first case. You want to start slow. You want to do the course that obviously helps you and teaches you the information as to how to do some of the work that you're looking to do, but you have to try it. That's the only way you're going to do it. So you really have to get stuck in as a DFT. And if you do have the cases, tell the patient, for instance, I can try my best. It might not work, but worst case scenario is, we can redo it. Or if your, for instance, supervisor is happy to obviously, help you. If it doesn't work out, then great. But the key to it is obviously trying, because if you don't, then when will you really, I guess. So as a DFT, I always found that I had that sort of cushion, that I knew end of the day, like, this is the year to do it, because as an associate you can still do it obviously, but as an associate it's a little bit more I guess challenging, because you're not in that sort of learning environment or that sort of protected environment, if you want to call it that.
Yeah. And which camera would you recommend a newbie to invest in?
Yeah, good question. I really kind of did a bit of research when I was looking into doing this. I essentially I went all out and I bought a really, really fancy kit. just because I thought I would probably use it for 20 years or so, which is still the same intention because, you know, the camera works okay. But I think a lot of people probably go for like a crop frame sensor. So that's basically, there's two types of DSLRs that mainly people go for, which is a full frame sensor, which is kind of a bit more expensive, and a crop frame sensor. There's not really much difference really in terms of for dental photography. So a crop frame sensor is cheaper, and that would be something like a Canon 750D or a Canon, I don't know, 200D or something like that. That's kind of what it would be. I think the 750D is probably a common one that people invest in as a start, as a beginner, because a lot of friends that I have, that's the first camera that they went to. It depends what system you want. If you want obviously a Nikon or a Sony or a Canon. For me, I only have experience using Canon, so I just went for a Canon. But you could probably look at kind of something like a Canon 750D, which is fairly reasonably priced, and it's obviously very good for you to obviously get photos on. So
yeah, that was a really good question. Thank you. And I'm not sure if you already answered this one, but somebody's asked it. I think you have already answered it, and it said, is a composite primer fine to use as a wetting resin?
Yeah, so same as what I mentioned before. I would still kind of stick to the wetting resin specifically, so like the Signum one or whatever other brand that you have, but definitely find a particular wetting resin, just because the primer isn't designed for that, because obviously it's more for the bonding that you're using the primer and the bond for, and that's obviously going to have resin in there, so it's going to stain. Whereas the wetting resin still does have a small amount of resin, so you need to make sure that you look at the sort of, I guess, ingredients, if you want to call it that, what's actually inside of the bottle.
And then when you spoke about using Teflon to imprint fissures, how do you stop Teflon from sticking?
Yeah, really good question. So the Teflon's like a really great piece of kit. So it's like literally you can get a massive roll for like really, really cheap from like one of these sort of B&Q, or so I guess one of these builders merchants and stuff. But I use it all the time for like retraction cord. Sometimes I'll stick a bit of Teflon in. I'll use it sometimes for floss ties with a bit of Teflon, and obviously for this, which is the stamp technique. The way to stop it from actually sticking is obviously the Teflon is like an interface. It's actually stopping your actual micro brush with the composite on it, stopping it from sticking to the actual tooth. So once you've done this, it will actually just peel away quite nicely. It doesn't actually stick to the composite because the composite's hard, it's cured, so it will actually not stick because the light cure will penetrate through the Teflon tape, so it won't actually kind of come off with the composite, if that makes sense. So it's kind of a barrier.
Okay, thank you. Ibrahim's asked another question.
Yeah.
Loving it. Do you use bulk fill or oblique layering for your large MOD composites?
Yeah.
And what would
go on?
Sorry. And what would be your reasoning for either or?
Yeah, that's a really good question. I do tend to use bulk fill a fair bit. It's just because I think the research now that kind of supports bulk fill is very good. So I quite actually, I don't use it for every case. I probably use still more kind of normal oblique layering and stuff, and normal, I guess, composites that you have to do incrementally at 2mm and stuff. But I do tend to use a bit of bulk fill. But the reasoning behind them, I guess, number one, what we've got in the practice. So that would kind of be a big factor, because sometimes obviously we're running low on the bulk fill and I'll just go for the conventional composites and stuff. But I think for me personally, it's just kind of looking at the research and seeing which one is well supported. And I think now it's kind of bulk fill has really good sort of evidence behind it to say it can give you good results. So I too tend to use a bit of bulk fill. But I do kind of change quite a bit. So I can't really answer that question as like one or the other. I do a bit of both. But it's kind of, I guess, whatever is easier at that time in terms of the case. So it's kind of case dependent, I guess.
Is there a time when you wouldn't use bulk fill?
Not that I can really think of. I don't think there's any reason not to ever use it. I think there's probably reasons that might be better to use a different type of composite, but I don't think there's any reason not to ever use it really that I can think of now.
Okay, thank you. That was just something I was thinking. And then another question. First, thank you for the presentation. It was really helpful. And then they've asked, if you use glycerin or anything else to get rid of the oxygen inhibited layer?
Yeah.
And is it important to even do that?
Yeah, so really good question, and I think there was a small photo of kind of, I guess, what we were referring to. So this is kind of it in the on the left side of the screen. Again, it's a bit zoomed out, so it might not be very clear with regards to the content. But the purpose is, obviously, we're using a little bit of glycerin to, I guess, make sure we overcome the oxygen inhibition layer, which is when you're doing a composite, you basically want one layer to stick to the other layer, right? Because you're incrementally building it up from the base upwards. Now, eventually what happens is, obviously, when you've done your final outermost layer, there is nothing to add on top of it because you've finished your composite, but it still kind of has the ability to have stuff stick to it. So what you need to do is what we call overcoming the oxygen inhibition layer, which is with glycerin. So you take a little bit of glycerin, which is in the third photo on the bottom left. That's kind of on top of the composite once it's cured. And it's like a bit of gel. You place it on there and you basically light cure it. And what that does is it overcomes, and it basically prevents you from having the ability to add more composite on. So it's fully cured now. The outermost layer is absolutely cured. Now, what that means is when it comes to, I guess, finishing and polishing, you don't have those sort of grainy bits that get stuck in your composite. You guys might remember, like, when you're doing a composite and you're doing the occlusal adjustment, or you're trying to make it smooth, you'll always get these really fine particles that stick into the fissures, and it kind of makes everything look really messy. And this is a way to kind of overcome that, because you've fully cured everywhere. And then when you are doing your kind of finishing and polishing, it's not going to be as, I guess, grainy and stuff. Those little grains don't come out as much. And it means that the composite is fully cured. And that's why I tend to use it. It's really important for anterior composites for sure, because you have to remember composite stains over time, right? So if you're doing anterior bonding, or if you're doing, like, for example, the class 3 composites we spoke about, you want to reduce the chances of it staining. So having the final cure through glycerin is so important, because that's obviously going to make sure the composite is fully cured, so it doesn't have those grainy particles and stuff.
Thank you. I just wanted to ask, how are you for time? Because we do have a couple more questions.
Yeah, I'm good for time. Yeah. Okay. The other thing I should add on to that answer is, in terms of, is there anything else that will overcome it? The oxygen inhibition layer. If you start to shave the composite back with a burr to do the occlusal adjustment, that will remove the outer layer anyway. So it does kind of, I guess, remove the outer layer and go to the underlayer, which is a bit more cured. But it's not really, I guess, as accurate as doing it this way, for instance, because you know that way you've fully cured, right? So I would always say this is the gold standard of doing it.
Okay, thank you. And Kayam has asked, why isn't the occlusal stamp technique used all the time for posterior composites?
Yeah, again, a good question. The only reason why it's not always done is because the occlusal, I guess, stamp technique is only for unrestored teeth. So let's say, for example, here, you can see on the first photo that there's actually no filling, or there's no hole in this tooth. So that means that you can take a stamp, or you can take I guess, a stent or an index, or whatever you want to call this technique. You can actually take a mold of that with the flowable resin. If there's already a hole in there, which most times there is a cavity already in the tooth when the patient comes to you, there's no sort of, I guess, there's no sort of platform for you to take an index of. So you can't use this particular technique. You have to make sure it's an unrestored tooth, because if it's not, or if it's even a restored tooth with a really nice anatomy, then fine. But most times it's going to be an unrestored tooth. It has to be unrestored, really, because you want to recreate the anatomy, right?
Yeah. I've got a private question then. Oh yeah. Someone's asked if you can recommend, they must have checked it out already, if you can recommend any cheaper kits to the LM Art kit, or is it best to invest in it for DFT onwards?
Yeah, again, good question, because this stuff is quite expensive. Like I mentioned at the beginning, like a lot of the stuff, as in I must have spent a majority of my salary on kind of dental equipment in terms of brushes, composite kits, obviously the camera, courses and stuff. So I understand with you guys completely. I think a good, first of all, you can buy, I think, some of the instruments, you can buy them independently, so you don't have to buy the entire kit. So you can find whoever is the local salesman or dealer for the kit. If you phone the company that, for instance, you're looking at, like OptiDent or whoever else you're using, you can find out who the local rep is for the company. And once you get into contact with them, you can just say, I want, let's say, 2 instruments. and they're like 40 quid an instrument or something. So you can, instead of buying the entire kit for the first go, you can maybe just buy one or two. The main ones I would recommend is definitely the really fine tipped instrument, because that's quite a nice instrument to use. And if you can, you probably want to get something like this, which is the posterior misura, which is what it's called. Again, it's quite helpful. But yeah, you can actually ask the reps to come out to you. When I bought mine, he came out, he brought the kit with him before I bought it. He let me kind of play around with them, and I worked out which ones I wanted. So yeah, you can do that as well. So feel free to kind of contact them.
Thank you. And we've got some questions asking about what loops you use, as in like which magnification and which company.
Yeah, great question. So loops, a game changer again, loops in the light. I bought those when I was in uni, I think in 4th year, and it showed me how bad my work is. So like, I think with the loops, you want to make sure you obviously invest in a kit that's going to obviously see you through for a few years at least, because it's quite expensive. I went for a kit through recommendation. The company's called Carl Zeiss. So it's like I guess they kind of specialize in optics. And it's really high quality sort of vision that I get. It's only 2.5 magnification, which I probably do want to go higher now, but it was great to start with. It's still what I use now for everything like checkups, all the way to kind of preps and composite and stuff. But I kind of spent, I think it was like just over £1,000 on them, £1,200. So they want that expensive, but the quality is really, really good for what I needed. And I really would recommend them. So they're called Carl Zeiss. Yeah, really good piece of kit.
Thank you. And we've got a question. What's the easiest way to remove composite veneers?
Oh, that's so tough to do.
Don't worry if you can't answer it.
It's an absolute, to remove composite veneers is like, it can be really, really time consuming. Even to remove a composite, like for instance, yesterday I had a really big composite in an upper left 6, and I was prepping it for a crown, and I was probably removing the composite for at least 40 minutes or 45 minutes, and it was probably an hour and a half appointment, so I had to do everything else. So I just removed the composite in 45 minutes or something, just because obviously the way composite sticks to the tooth is different to an amalgam, right? Because an amalgam, you just can section it and just flick it out and it comes out quite quickly. It's the same for anteriors. Like when you're doing composite veneers, because they're bonded to the teeth, you have to be so careful to make sure you don't want to cut the enamel or whatever's underneath the composite, because you don't want to damage the natural tooth. But what you can do in terms of removing composite veneers is there are particular composite removal burrs. So they only cut the composite and they don't cut the enamel. So I remember seeing a dentist use those, which are quite useful. You can also obviously etch the teeth like at stages. So for example, if you know you've got composite veneers on the teeth and you've removed like some of it, and you've realized that there's more composite, or you're unsure if there is more composite, you can etch the teeth and wash. And the way that the composite will come up after it's been etched will make you identify that there's still composite there, or there isn't, for example, if you're a natural tooth. The other tip is that you can actually get this blue light from Amazon or kind of eBay for like £2 to £5 or something like that. It's like really cheap. And the blue light effectively, when you shine it onto the composite, if anyone has any questions just about that particular thing, just DM me and I'll try and send you a link. But it actually shows you the composite because it only goes through the composite, not the tooth. So that's quite a useful tip. So you can buy it for like literally a few quid on eBay.
Thank you. That was really useful. So we go. Do you find your composites eventually stain in the long term, and is there a way around this?
Yeah, composites will like, as in I try and be as meticulous as I can when it comes to like bonding protocol, and obviously making sure everything's as clean as possible, like sandblasting and etching and bonding for appropriate lengths of time. But it will stain, like at the margins and stuff. It does stain. It's just one of those things that it's kind of, I guess, gonna happen, because you got to remember like the patient's diet and kind of just general things. It does pick up those stains over the long term. I've obviously, like I said, I've only been graduated since 2018. So in terms of the number of cases that I've done, in terms of like recalls and long-term sort of, I guess, recalls, it's not many because I've not been working long enough. So I can't tell you and show you photos of cases that look lovely on day one and look really bad after 3 years, because I don't have those yet. I'm sure there are going to be out there, but I don't have them at the minute. But some of the dentists that I've gone on courses and stuff with have shown that stuff, and it seems inevitable, you know.
And I had a question on my own as well. You know, you reckoned, was it Dental Italiano or Style Italiano?
Yeah, Style Italiano.
I've seen people like carving wax and soap and anything they can get their hands on. Have you got any other tips for learning dental anatomy?
Yeah, so I remember a few people recommended that to me as well, but I just didn't really have the patience to go through with that in terms of doing the carving, because I just felt like it was, I didn't kind of have a strategy to kind of get the result. I knew people were carving and it was great, but the Style Italiano method that I kind of went over with the essential lines that they call it, that was effectively like a copy and paste thing that I effectively learned. I literally just sat down, revised these sort of patterns, drew them out onto paper, and then as soon as I memorized those in my head, I knew that when it came to a cavity or a tooth, I could just literally think back to what I had and recreate it as best as I could. So that's kind of the tip that I felt best worked for me. But I know a lot of people do advocate kind of carving, and I know a few people that do that, and it does seem to help. But definitely have a look at these resources, because their stuff is also free. So you can access all their articles and stuff. It's really useful.
Yeah, definitely will do. And for everyone as well in the webinar, definitely check out the Kaizen Dental website. The clinical tips will be really helpful if you found this helpful as well. That's the QR code for it, if you want to scan that.
Cheers. Definitely.
And thank you, Dr. Bal Sohal, for doing this webinar. It's been really great. We appreciate the time you've taken to do the webinar and answer all the questions as well.
No, I'm really, really glad, and like I said, really grateful to be asked, and hopefully it's been helpful. And you know, like I said, if anyone obviously has any other questions and stuff, I'm obviously on social media and Instagram and stuff, so feel free to ask me anything that's obviously been in this webinar that's not really clear, or if you want me to go through anything again, I'm happy to kind of, you know, cover it again. So yeah, by all means.
Perfect. Thank you a lot. Anybody got anything else to say? Niji, Owen?
Just say thank you so much again, and everyone, if you're from Manchester or you are using the Society app, please go on the feedback section, because then you can get a certificate for attendance. And we've got our next speaker next week, who is Dr. Vinay, who will be talking to us more about kind of the jump between dental school to DFT, and with everything that's going on at the moment with all the interviews being cancelled, he's going to give us some tips on SJT, which is very much needed. So yeah, make sure you tune into that. So that's next Thursday at 7:30. And yeah, thank you so much again. We've really enjoyed that. It was incredible. I'm
really glad. Thanks, guys. Yeah, I hope it's been helpful. Like I said, if any other questions, let me know, and I'll be more than happy to answer those.
Yeah. Thank you so much.
Take care.